Hello, my name is Lexi Turner. Today I'm going to be discussing the health promotion plan that I have came up with in regards to hypertension. It is a disease that's commonly encountered at the primary care clinic in Mountain Grove that I'm going to be completing my practicum at. Like I previously mentioned, I will be discussing hypertension management that's tailored to the primary care population in Mountain Grove, Missouri. The purpose of this presentation is to demonstrate how advanced health assessment skills and evidence-based practice can be applied so that a personalized, culturally sensitive health promotion plan can be enacted. The focus is patient education here. By teaching patients to understand their condition, following treatments, and adopting healthier lifestyle changes, I do believe, and evidence does show, that there is a reduction in long-term risks such as heart attack and stroke. At the Cox Health Primary Care Clinic in Mountain Grove, hypertension is one of the most frequently managed conditions, particularly in older adults. The clinic serves largely a rural and underserved population of people, and according to CDC data, nearly half of adults in Missouri have hypertension, yet only about 25% achieve adequate control. There are some barriers in regards to location, and this includes transportation difficulties, financial strain, and a limited access to cardiology specialty services. And this only further increases the burden. These statistics justify hypertension management as a priority focus for this clinic. This infographic from Million Hearts shows that about 47% of U.S. adults have hypertension, which translates roughly to 116 million people. Of those, 79% require both lifestyle modifications and medication, while only about 21% can be managed with lifestyle changes alone. Importantly to note, blood pressure control remains a major challenge. Nearly 74% of adults on medication remain uncontrolled, which shows a significant gap in hypertension management. I think that it's important to understand hypertension and to discuss the disease process itself before we jump into management. Hypertension means that the heart and the arteries are under extra strain. Over time, this can wear down blood vessels and organs and raise the risk of stroke, kidney disease, and even heart failure. Many patients don't feel symptoms, which is why it's called the silent killer. But it's important to explain this to patients so that they don't rely on feeling fine as proof of blood pressure control. A common myth is that blood pressure medicines can be stopped once blood pressure improves, but in reality, stopping without provider guidance can cause dangerous spikes. Patients need to recognize emergency warning signs such as chest pain, sudden shortness of breath, weakness on one side, slurred speech, sudden vision loss, or if home readings show greater than or equal to 180/120. This is a hypertensive crisis and requires calling 911 immediately. Patients should also be told when to contact their provider for an earlier intervention, such as persistent readings above 140/90 or new swelling, dizziness, or headaches. Hypertension treatment often begins with diuretics, which helps the body get rid of excess salt and water. Other common medicines include ACE inhibitors or ARBs that relax blood vessels, calcium channel blockers that ease the heart's workload, and beta blockers that slow the heart rate and reduce pressure. Each class of medication has potential side effects. For example, ACE inhibitors may cause a dry cough, calcium channel blockers can cause ankle swelling, and diuretics may lead to increased urination. Patients should be reassured that not all side effects are dangerous, but it is important to report them so that adjustments can be made if necessary. A common mistake that patients make is stopping their meds when blood pressure improves. I would stress that blood pressure meds control the disease but do not cure it. Skipping or stopping meds can lead to a rebound effect and increase the risk of stroke or heart attack. To help patients adhere, I would recommend pill organizers, phone alarms, or even smartphone apps that can give reminders. Linking medicine times with daily habits like brushing teeth can also help. Cost can be a real barrier, especially in a rural Missouri community. Options include generic medications and a Cox Health Pharmacy Assistant Program for patients who qualify. I would make sure to screen patients for financial concerns so that we can connect them with the appropriate resources. Lifestyle changes are just as important as medicine in terms of blood pressure control. The DASH diet and the Mediterranean diets are proven to reduce blood pressure. I would encourage patients to eat like this in simple terms. Essentially, more fresh produce, whole grains, beans, fish, lean meats, and cut back on processed foods with added salt. Patients should aim for less than 2,300 milligrams of sodium a day, with an ideal goal of sodium being around 1,500 milligrams per day. The recommendation for exercise is at least 150 minutes of moderate activity per week. In Mountain Grove, a lot of these patients are farmers, and so I would emphasize that yard work, walking, and active chores would count towards this goal of exercise, not just the traditional formal exercise spent in a gym. Smoking greatly increases the risk of stroke and heart attack, so I'd be sure to use motivational interviewing to support quitting and then provide referrals to quit lines and local cessation programs. Alcohol should be limited to 1 drink a day for women and 2 for men. Also touching on poor sleep, because poor sleep can increase blood pressure. I would recommend setting a routine bedtime, limiting caffeine in the evening, and making sure to promote a good sleep environment by making sure that it's quiet and dark. In terms of culturally relevant examples, it's essential to make recommendations that are culturally appropriate. For example, if a patient enjoys traditional Southern foods, I would suggest baking or maybe using the air fryer instead of the traditional frying in deep oil, or using herbs instead of salt. Family support can make changes easier, especially in rural communities where meals are shared. Respecting faith and cultural practices builds trust and makes lifestyle guidance feel supportive rather than restrictive. Home monitoring is critical for blood pressure control. Patients should check their blood pressure twice a day at least, typically in the morning and in the evening, using an upper arm cuff while seated and rested. Keeping a written or a digital log makes it easier for providers to spot trends. Patients should also weigh themselves daily if at risk for heart failure and report sudden increases of 2 to 3 pounds in a day or 5 pounds in a week. Other symptoms like dizziness, headaches, vision changes, chest pain, or swelling should be tracked and reported right away. For tools, I would recommend validated home cuffs and smartphone apps that store results. Studies show that apps with reminders and feedback can significantly improve blood pressure control and medication adherence. Journals are helpful for patients that are less comfortable with technology. Wearables such as smartwatches can track daily activity, heart rate, and sleep, which supports lifestyle modification goals. Technology helps with engagement by sending reminders for medications and appointments and allowing patients to share data electronically with their providers. This can reduce missed visits and allow earlier adjustments. In addition to home monitoring, routine lab tests are needed. A CMP to check kidney function and electrolytes, especially if on diuretics, and a lipid panel to check cholesterol. An EKG is recommended at baseline and for those with symptoms like chest pain or palpitations. Educating patients on why these tests matter helps increase follow-through. For example, you could say, this lab tells us how your kidneys are tolerating your medication, and it makes the process feel a little bit more personal and important. Patients with hypertension should have blood pressure measured at every healthcare visit and encouraged to do home checks twice a day, like we just mentioned. Hemoglobin A1C should be checked yearly to monitor for diabetes, which can often coexist with hypertension. If a patient is already diabetic, checking this every 3 to 6 months may be appropriate. A lipid panel should be done every 4 to 6 years in healthy adults, but more often if you're a high-risk patient, such as having obesity, being a current smoker, or a history of smoking, or having a strong family history of abnormal lipid panels. Kidney function tests are essential because high blood pressure can damage kidneys sometimes silently. These should be done annually or more often if abnormalities are found. In addition to that thought, we know that ACE inhibitors can cause increased creatinine values, so knowing baseline creatinine value before we start ACE inhibitor therapy could be beneficial in identifying if the creatinine values were to increase. General age-appropriate screenings still apply, so mammograms starting at 40, colonoscopies at 45, and then pap smears is recommended. Hypertensive patients are often at higher cardiovascular risk, which make preventative screening especially important. In terms of specialist referrals, these include cardiology if blood pressure is uncontrolled with multiple meds or if there's a sign of heart damage. Nephrology should be included when kidney function worsens despite blood pressure control. Dietitian referrals are evidence-based and are shown to help patients adopt the DASH diet and reduce salt intake, which helps to improve blood pressure control. Follow-up visits and repeated testing. After diagnosis or med changes, patients should be seen every 1 to 3 months until blood pressure is at goal, so less than 130/80. And then once the blood pressure is stable, follow-up every 6 months is reasonable. Lastly, patients often forget when screenings are due, so printed handouts and checklists or wallet cards are helpful. Patient portals can send out automated reminders for labs and visits, and text reminders or brochures with QR codes that link to simple education videos could also be effective. Patient education must be matched to health literacy. Many rural patients prefer plain, direct explanations. Using the teach-back method, such as, "Can you show me how you check your blood pressure at home?" ensures understanding. Visual aids, diagrams, and bilingual handouts can be helpful if English is not a patient's first language. Respecting cultural and faith values, such as including prayer groups or family and decision-making, can support adherence. In rural communities, the primary care clinic is central to managing high blood pressure through regular monitoring and routine management. Local health departments provide low-cost immunizations, blood pressure checks, screenings, and they truly do help overcome some rural access barriers. At the national level, Healthy People 2030 sets evidence-based goals for reducing cardiovascular disease. For hypertension specifically, one key objective is listed under HDS 04, and it states to reduce the proportion of adults with hypertension whose blood pressure is not under control. The baseline is 45% of adults with hypertension, and the goal is to reduce that number gradually to 41.9% by the end of the decade. The AHA supports patients with tools, recipes, and home blood pressure monitoring instructions. The CDC hypertension campaigns focus on providing culturally appropriate, low literacy resources that align with digital health initiatives. Community and clinic-based programs include support groups and health education classes, which can improve patient empowerment. Anecdotally, my husband's grandma actually uses silver sneakers through her local YMCA. This is great for her health and is great for socialization in the isolation that can come with being a retiree and a widow. In Mountain Grove and other rural communities, patients face several barriers to managing hypertension. Financial challenges are common as many patients are uninsured or underinsured, making it difficult to afford medications, healthy foods, or frequent clinic visits. Access barriers include transportation issues, long travel distances to specialists, and limited appointment availability. Cultural and language differences can create misunderstandings about treatment plans. For example, some patients may rely more heavily on home remedies or may mistrust the healthcare system due to negative past experiences. Health literacy is another barrier as patients may not fully understand medical terms, medication instructions, or the importance of regular screenings. To overcome these barriers, my plan emphasizes plain language, visuals, and the teach-back method to ensure patients fully understand their care. Utilizing telehealth may also be a valuable option to increase follow-up attendance. For Spanish-speaking patients and others with limited English proficiency, interpreter services and translated materials provided by Cox Health can bridge language gaps. I would also integrate cultural beliefs and practices into the care plan when appropriate, such as acknowledging the importance of family decision-making, faith, or traditional foods and health management. This approach shows respect and builds trust, making patients more likely to follow through with their care. To summarize, hypertension is one of the most common chronic conditions in our patient population. Education about the disease, medications, lifestyle, and self-monitoring is essential. Evidence shows that advanced practice nurses significantly can improve blood pressure control through patient-centered interventions. As I begin my clinical practicum, my goal is to empower patients through education and culturally sensitive care so that they can better manage their hypertension and reduce long-term complications. Here is the first page of my full reference list, and here's the last page of my full reference list.